You can start, Dr. Singh.
Okay. Welcome, everyone, to the latest episode of Spine Time. Thank you all for joining us on Wednesday, July 28th at 5 p.m. Eastern. We have a very special guest today, Dr. Larry Bonasser, joining us from Ithaca at Cornell University. Many of you might have been expecting Dr. Roger Hartle, as the initial invitation suggested. But trust me, you're in for a very special treat, and we will not leave any question unanswered today. So it's just 3 minutes after the hour, so I figure we get started. And remember to use the chat function to drop in some questions. We will try to get to those as many as possible. Try to keep them kind of generic regarding the topic and less about your personal condition. Obviously, at some point, we would love to see you here at the Weill Cornell Spine Center. So just a little bit about us. We are the Weill Cornell Center for Comprehensive Spine Care. We pride ourselves in being very interdisciplinary, working with neurosurgeons, neurologists, pain management, physiatrists like myself, physical therapy, and then integrative health with mindfulness and acupuncture and a bunch of other services. And today we have a scientist with us, which is really helpful in getting us from the bench to the bedside. And that's kind of what we're going to talk about today. So about me, I'm Ricky Singh. I'm one of the co-directors here at the Spine Center, specializing in physiatry or rehabilitation medicine. And my co-host today is Dr. Lawrence Bonasser, or Larry Bonasser, professor of biomedical engineering at the Sibley School of Mechanical and Aerospace Engineering, again at Cornell University up in Ithaca. So today's topic is about regenerative medicine. And, the word stem cell gets thrown out a lot, and we want to be really careful in not using that word. Patients come in asking, I want a stem cell treatment for my spine. And, we quickly try to redirect them saying it's not really a stem cell when we do it clinically. Certainly in the lab, and Dr. Bonasser will talk about this, we can call it stem cell therapy. But we really like to use the word regenerative medicine or orthobiologic. And basically what we're trying to do is to restore some of the tissues in the body that have degenerated, whether it's with overuse or with time and age related. And, we all have these stem cells or signaling cells circulating in our body. When we get cut, our body quickly sends these growth factors and cells to the site to repair it, which is why you see a clot and then eventually new skin forming. When we break a nail, things like that, when we fracture a bone, we see healing of the bone again because circulating growth factors and proteins in the body help us facilitate that healing process. And some of the areas in the spine where we like to target and use these regenerative medicine techniques are the disc. Remember, the disc is kind of that soft jelly-like donut in between the two bones of the spine. And those you can try to restore the height of the disc with some of these biologics, which Dr. Bonasser is going to talk about. Some of the joints in the spine, and we've had pretty good success using some of these orthobiologic or regenerative medicine agents in the facet joints and the sacroiliac joints. And patients who have pain coming from these joints don't like to stand up tall. When they're sitting down, they feel comfortable. When they stand up and they start walking, then they get acute back pain. And that's when the joints are rubbing up against each other. So sometimes we do treatment called radiofrequency ablation, and sometimes we do stem cells or regenerative medicine. So there are different places where we can collect these growth factors. The most common thing that we use is platelet-rich plasma. You may have heard of it through some athletes and in social media. And basically, again, we have growth factors circulating in our body. And in order to collect that, we take a sample of blood from a vein, and we spin it down, get all the growth factors. And we use the platelet-rich plasma, which is right here in the middle, and inject that into various parts of the body, whether it's the joint or the spine or things like that. And then mesenchymal signaling cells, which is probably a more accurate way to describe bone marrow, and also adipose, which is the fat around our bellies. There's a lot of signaling cells in those tissues that we can harvest. We can take them out and then concentrate them and inject them back into different areas to promote your body's own restorative mechanisms just to work more efficiently. And again, we have good clinical trials going on with using bone marrow aspirate for knee arthritis and for intradiscal applications. And here's one of those studies, just looking at bone marrow. When the disc degenerates, you can see a kind of healthy disc up here. You can see a bulging disc down here, and then degenerative discs way down at the bottom. And when those are the painful discs, we try to inject some type of regenerative agent into those areas. And again, the data is looking promising. There's some studies that have 3-year data, and we're almost there. And so it might be a consideration for your spine. So let's take a little step back and talk about the science of stem cell therapies. And I'm going to pass it over to Dr. Bonasser. Larry, it's all yours.
Yeah, thanks, Ricky. So it's really a pleasure to talk to you all today. Maybe I'll just take a minute or so to tell you why I'm sitting in front of my camera up here in Ithaca, New York, talking today. So I'm a faculty member, as Dr. Singh said, in biomedical engineering and mechanical engineering here at Cornell. And I've been working with Dr. Hartle and starting to work with Dr. Singh now more recently on regenerative medicine therapies, specifically targeted at the spine and the invertebral disc. And as Dr. Singh was saying, we thought a nice topic for today, or at least one of the things that we wanted to talk about, were stem cell therapies. And so, one of the first things that is challenging in understanding what these therapies are and what they do is that there's this alphabet soup that you may see associated with this. And this is in the little bubble in the top left of the slide. So you may hear PRP, MSC, BMSC, IPSC, MSC, and you'll notice that many of these have SC at the end, and what that SC stands for is stem cells. And at the point where we are right now in 2021 is that there are a small number of studies that have started to think about how one can harvest and process these cells. They can be, as Dr. Singh said, harvested from blood. They can be harvested from skin. They can be harvested from bone marrow, and injected in various points in the body. Typically, I would say right now, the most frequent applications have been in orthopedic applications like the knee, or in the spine. So if there's any football fans on the call, that's Peyton Manning. About 8 or 9 years ago, Peyton Manning got a stem cell injection in his spine and his neck after some injuries on the field, with the goal of trying to regenerate tissue in the spine and restore function. And just to give some perspective, so this idea has been around for a while, but I would say it's only in the last 5 years or so that this has gotten some traction clinically, at least of any significant nature. So the little graph on the right is showing you the number of clinical trials that use injected stem cells for various therapies. I've broken this down into two. One is arthritis and one is degenerative disc disease. And you can see, especially in the past 5 years or so, this has really taken off. So if we go to the next slide, I mean, one of the things that we hope to accomplish in this meeting is to give you a little bit of science about how these work. So, and there are really two evolving ideas here. So I know this is a busy slide and there's a lot on it, but I want to convey just two simple ideas from this slide. One is, if you look at the bottom right, and that's a reference to an article that came out 30 years ago now. So this was pioneering work. That's kind of when stem cells, specifically mesenchymal stem cells that you would get from bone marrow or fat, were first identified. And at that time, the kind of prominent idea was these, as stem cells, these cells have the ability to turn into, or to differentiate, is the word we use scientifically, into all different kinds of tissues. So you can find these cells in bone marrow. They're basically about 1 in a million. 1 in a million cells in bone marrow are these stem cells. And if you expose them to the right signals, these stem cells can become bone, or they can become cartilage like you find in between vertebrae in the invertebral disc, or they can become muscle, or they can become marrow or tendons or ligaments or adipose, or all sorts of other tissues as well. So for many years, for 3 decades, there's been a huge amount of study in saying, can we use these therapeutically? Can we isolate them? What are the best cells? And then can we find ways to turn them into the appropriate cell that we want, and then inject them into bone or cartilage or muscle or wherever we need them? And I would say this was the prominent idea for at least 25 years. But if we go to the next slide, the more recent ideas are that stem cells work in a slightly different way. So again, this is a review article that was published earlier this year, 2021, in Nature, and it encapsulated work from, say, the past 3 or 4 years. And this has identified recent mechanisms by which the stem cells, which in this case are colored kind of in blue, interact with cells in our body and deliver to them various things. It could be growth factors, it could be cytokines. In this case, it's actually mitochondria. It's the powerhouse of the cell. What's been a huge development over the past less than 5 years is demonstrating that stem cells can actually donate mitochondria to other cells in the body, either by directly making a little tunnel to deliver them via a little pipeline, or encapsulating them in little bubbles that are called microvesicles and spewing them out into tissue so they're gobbled up by other cells, or even directly donating them, sending them out into tissue so they can be grabbed by other cells and revitalized. That in many cases, if you think about a degenerated disc, like Dr. Singh had on his diagram, so sometimes the cells in those discs are dead, and sometimes they're not dead, but they're just sluggish. The scientific word is senescent. They're there, but they're not doing anything. And if anything, they're causing trouble. And it turns out that one of the things that we now know stem cells will do is they will directly try to revive those cells by donating chemical signals, or perhaps even donating mitochondria.
Can I ask you a question? You know, a lot of patients come in and they bring their MRIs and they show, just like I showed you the picture, where you have a couple juicy discs, they're nice and bright. And then at the bottom, they have darker discs that are a little flattened. And the MRI, the radiologist has read it as degenerative disc disease, severe disc degeneration. And patients come in, you know what, I'm thinking about stem cells. I heard about it or read about it. Can we inject the stem cells and pump up that disc to make it look like the neighboring disc? Does it actually regenerate the disc that is now not as hydrated as it once was?
So I mean, that's the idea behind the therapy, right? And I think, you know, you see more of these patients than I do, but my understanding of the clinical literature is, you know, that the key operative word is can. And I think the answer to the can word is yes, we can, if you will. It can work, but we're still in some ways struggling to understand why it works when it works, right? And that's why the difference between, you know, this slide and the last slide is important, because if we don't know why it's working when it's working, then we don't know how to make it consistent, and we don't know how to make it better, right? So it could be that those cells are themselves puffing up that disc and making new tissue or new matrix, or it could be that it's reviving those cells that are there, right? So we're right now we're at the stage where the potential of these treatments has been shown, but in order to take that from a case where it works sometimes to it works most of the time, or it works all the time, we need to both understand the process better and make improvements. So not only, so the example on the left is some work from a project that Dr. Hartle and I published a couple of years ago. And it's on the idea of, rather than simply injecting just cells, we're injecting a carrier for cells that will keep them where they want to go and will facilitate their organizing new tissue and connecting with the existing tissue. So engineering systems so that the cells work better is one approach, and then engineering even better stem cells. So if, for example, we know that the way that they're working is by donating mitochondria to neighboring cells, how do we facilitate that process? Can we use all this cool molecular biology technology that we know now, you know, genetic engineering and gene therapy, to make stem cells that are even better at donating mitochondria or whatever else is puffing up those discs and making them healthy?
Yeah, you know, one thing I want to emphasize, especially for the listeners, is, you know, we're very fortunate here at Weill Cornell to have a collaboration with Cornell University. You know, we're doing this scientifically based. You know, there's a lot of ads out there, and I've seen billboards of stem cell clinics and USA stem cell clinics. You know, a lot of these have been largely shut down by the FDA because They are making promises that they can't keep. They're putting stem cells, quote, into the IV and saying we can cure stroke and Alzheimer's and a bunch of different neurodegenerative conditions. And, here we have Dr. Bonasser with us, starting from the science and not putting the cart before the horse and saying, guys, take a step back. We know there's potential, but why things work when they work, that's what we want to find the answers to, so we can give the patients the right dosing, the right techniques and innovation to deliver the best outcome. So certainly we appreciate all the scientific work that you guys are doing up in Ithaca. Tell us a little bit about that. There's a book that you and Dr. Hartle co-authored on the biological approaches for disc degeneration. Tell us a little bit about what some of that science is showing.
Yeah, so there are, as I said, there are many approaches to this. And I think you can branch them out into two categories. One in which you're transplanting cells with the goal of the cells that you're transplanting being the things that make the new tissue. And the other is transplanting cells or other agents that are trying to rev up the tissue that's already there. And as you said, there are folks who are kind of are pushing the envelope and saying, let's inject cells and hope for the best. And sometimes they get good outcomes. But clearly, the best approach in the long term to get the best outcomes is to understand the mechanism by which these transplanted cells are doing their thing, right? And so there are a couple of different approaches to this, right? So we know, as Dr. Singh said at the beginning, that you can think of the disc almost like a jelly donut, where you have an outside, more rigid structure that in the disc is called the annulus fibrosus. And sometimes that annulus fibrosus gets ruptured, right? So we all have taken that jelly donut and squeezed it, right? And if that jelly leaks out, that stuff is what is impinging on nerve roots and causing pain. So getting rid of that stuff that's leaked out is important. But we and others have done some work with the idea of trying to make a patch whereby you can prevent more material from leaking out. And that's what this diagram is showing. So kind of one approach to this is to kind of patch the tire. And this is appropriate for, I saw a question that came up in the chat about who are these, what kind of patients are these therapies good for? And I think it depends on the therapy as well, right? So these kinds of therapies are aimed at patients who have herniations, who are diagnosed with herniations and have defects in that outer portion of the disc that can be patched, right? And that patching is facilitated by including cells in that patch that can regrow tissue.
Yeah, just going along with this specific condition, when a patient's disc, the nucleus kind of bulges through and is pinching a nerve, the treatment for the most part through Dr. Hartle is a microdiscectomy. So through a small incision, through a small microscope, you can go in and remove that little piece of disc. Now, if you do that, you create a little defect in the ring, and that's where some of these biologics can come in to repair that ring and prevent more jelly from squirting out. Someone else asked a question about who's a good candidate for this.
Right.
And it's tough because we need to predict where the pain is coming from. And that's one of the challenges in pain medicine in general, but certainly in the regenerative space. If we find that your disc itself is the cause of pain, and the way we do that is something called the discography, where we put a needle inside the disc and we pump it up with a little bit of contrast, and the patient says, "Whoa, that's my pain." That kind of perfectly reproduces the pain that I feel. Then what we can do is offer an intradiscal regenerative treatment, whether it's PRP or bone marrow, because now we know that that's the pain generator. Now, discography is not a perfect test. Again, I'm putting a needle into your spine and saying, does this hurt like it normally hurts? And that's obviously tough to answer. But that's kind of how we streamline the process to make sure we find the best candidate. Dr. Bonasser, let me ask you. Yeah, go ahead.
Can I add to that as well? I think another really important consideration is stage of disease, right? So you had that wonderful diagram before. if you are at the point where the disc is completely collapsed and there's no space, if you are at the bottom part of this, it's very unlikely that a stem cell injection is going to help, right? It's not going to, at least the current state, or to be honest, where we're going to be in the next decade. Simply injecting some cells into that space is not going to get you there. A cell-based therapy is really much more towards the top, right? With an early stage disease, either with very small amounts of thinning, or you can find a bulging disc or a recent herniation. That's where these therapies are most likely to be most effective, right? Whereas much more advanced disease is less likely to be impacted by a stem cell.
And we kind of see that, when we look back at our data and our outcomes, whether it's knee arthritis or disc degeneration, we find that there are the better responders and the not so great responders. And now looking back at our 2, 3, 4-year data, when someone comes in with a disc that looks like this way here at the bottom, we kind of have a realistic conversation with them. We're saying, listen, you probably are a candidate for surgery, so they can go in and decompress and fuse you. Could we put an orthobiologic like bone marrow PRP in there? Yes, we could do it. But remember what Dr. Bonasser was saying, these cells that we transplant from your bone marrow or from your adipose into the disc don't actually turn into the disc. They're actually telling the cells there, do your job better. You've been lazy or sluggish, turn on some collagen producing cells and do your job better. But if nothing is there to begin with, then it's really tough to get a great outcome.
I really love the orthopedic analogy too, right? So in the same way that not all arthritis is the same. Some people have arthritis because they tore their ACL, and some people have arthritis because they have a dysplastic hip, and some people have arthritis because they're obese. Some people have arthritis because they have some other malformation that causes their joints to be malaligned. And the solutions to those things, to those cases, even though they're all arthritis, are different. And the same thing applies to degenerative disc disease. Did this arise from a malalignment of the spine? If so, that might need to be fixed first. Did it arise from trauma? Okay, that's a different etiology than from just a herniation that occurred because of degeneration. We know, for example, people who are diabetic are much more likely to get degenerative disc disease, and we have some clues about why that is. But the person who had trauma and the person who has diabetes, they might have MRIs that look exactly the same, but we're very unlikely to have success treating both of them the same way.
Right. Someone asked a question about these treatments being FDA approved.
Yeah.
And, the FDA is really looking at this closely. Like I mentioned before, they're shutting down a lot of clinics that are doing things that are not ethical, that are all based on financial and not really outcomes based. So what the FDA has done is regulate some of the techniques to harvest these cells. So PRP, we have kits that are FDA approved to extract PRP. Bone marrow, we have kits that are approved to extract bone marrow. So when you then take that product and inject it, it's technically considered off-label. And I'll give you a very good analogy. Some of you are patients of mine that have come and seen me, and we've done something called an epidural steroid injection. Now, steroids are FDA approved for something. They're not FDA approved for epidurals. So when we do epidurals, they're technically off-label, but we do them and the FDA says, okay, because we have so much data to support their benefit and to show that there's no adverse events. So it's technically off-label. So the same holds true for some of these regenerative procedures, is that the technique in getting the cells is approved, but we are using it off-label. And it's for this reason that a lot of these treatments are not covered by insurance. And that's why we partner with Dr. Bonasser, Dr. Hartle, of course, and we study this and we present data to insurance companies and say, listen, especially for knee arthritis, I mean, cortisone, I've said this so many times on previous webinars, cortisone is so deleterious to the health of the joint, yet we still inject it because patients do get a good short-term response and there is some benefit, but we know these orthobiologics have a much longer outcome than cortisone, yet insurance companies don't want to pay for that.
Yeah, so I'd like to say a few words on this as well, right? So it's complicated in a couple of different ways. It's we probably over the past year have all become much more aware of what the FDA does and doesn't do and how they work than we ever have been with good cause. So to the broad answer, like, are these approved? There are some fully approved FDA therapies involving stem cell injections. There are some for sure. There are a bunch more that are currently in clinical trials. Again, if you look at the slide before, a great website is clinicaltrials.org. That will tell you a lot about the procedure. I think it's on slide 8. It's a great, you can get there, it's free, anyone can go there. Go to clinicaltrials.gov, and it will tell you, you can type in stem cell degenerative disc disease, and it will tell you every active clinical trial and where they are in the country and what the treatment is and what it's aimed at. A tricky part of this is because a lot of these are blood derived, there's a bit of a loophole in the FDA's regulations that make it look like from a regulatory perspective that it's almost like a blood transfusion. I take your blood out and I do something to it and I put it back in you. The regulations are a bit looser on that. And Dr. Singh is correct. They're currently, the FDA is trying to tighten those up a bit, right? Because it leads to a little bit of a, cowboy medicine where people do exactly what Dr. Singh said. I'm getting stem cells, even though what they're doing is very crude and they're taking blood out and they're putting it in a machine, and what comes out, they think are stem cells, but they don't know how many. And what comes out of me and what comes out of Dr. Singh's blood is very different. And it really is kind of the Wild West. So definitely, buyer beware when it comes to these cases. A treatment that has been scrutinized by the FDA and approved is different than one that fits into an FDA loophole. So just because something is allowed by the FDA doesn't mean it's approved by the FDA. Those are different things. And as always, I would encourage people to use and to seek out approved therapies because they've gone through this rigorous examination, right? And there is an important part of that process, which Dr. Singh mentioned, that is off-label homologous use, right? If we're using a particular preparation of stem cells and it's approved for reducing pain in the knee, it's not unreasonable to try to inject it into the disc as well. So those are also quite reasonable, but there really is a lot out there that can be very confusing. Right. And so, seek out those treatments that have already been evaluated by the FDA. That would be my advice.
And you kind of mentioned one of the questions I was asked about using gel similar to what we use in the knee for arthritis. Are we using that in the disc? So Larry, I'll let you kind of answer that question.
Yeah, I mean, these trials and investigations are ongoing. I mean, I would say in general, the therapies that are available for spine are lagging what's available for the knee by a good 5 to 10 years, right? And part of that is just this approval process. So if they're not here now, they're coming. I guarantee you that just about anything that shows really good efficacy in reducing pain and in encouraging, cartilage regeneration in the knee is very likely to be high priority for trial in the spine. So it might take a few years to get there, but they're coming. They're coming for sure.
And the key in using a lot of these regenerative treatments is, again, what is the diagnosis? What is the causative pain factor? So someone asked a question about spinal stenosis. Yeah. Remember, spinal stenosis is when inside the spinal canal, all those nerves are being compressed, either due to arthritis, due to genetics, due to a big disc herniation. Right. So the last thing we want to do is put more stuff into the spinal canal and create a tighter and already tight space. So we rarely, if ever, or I'd say never, use a regenerative treatment for spinal stenosis because it just doesn't make sense there. Now, I've had patients come in saying, I got an epidural stem cell procedure for my spinal stenosis. Did it work? No, of course not, because that's not what it's used for. How much did it cost? $8,000. So like I said, there's a lot of people doing a lot of unethical things out there for, financial reward and not for outcomes. So spinal stenosis is not one of the indications that we would use for a regenerative treatment.
Right. In the same way, I agree completely. In the same way, if, for example, you had hip dysplasia and you had arthritis due to hip dysplasia, if you don't correct the hip dysplasia, injecting as many cells as you wanted to the hip isn't going to solve your problem.
Right.
Because even if you do manage to regenerate that cartilage, it's going to go away because you have this, malalignment of your hip. In the same way, if you have stenosis, you have to take care of that stenosis first before you can go about trying to regenerate the tissue that was destroyed because of the stenosis. Otherwise, that tissue you regrow is just going to be destroyed again.
That's right. One of the questions was, how long does it take to work and how many treatments do you need? We don't know the answer to all of this yet, which is why we study it and see what the longevity of these treatments are. For the most part, what I tell patients is, unlike a cortisone, when we do a steroid injection, pretty predictably in 3 to 5 days, you're going to feel better because the inflammation is going to go down. I'm using a local anesthetic, so the pain will be a lot less after the procedure. But when we do these regenerative procedures, such as PRP or even bone marrow aspirate, it's a pro-inflammatory treatment instead of an anti-inflammatory like cortisone. So I expect the patients to be in a little bit of discomfort for a few weeks because the cells are turning on, they're signaling other cells, come to the knee, come to the spine, do your job better, turn on. So I expect there to be some discomfort. And I also tell patients to be patient because nothing is going to happen for at least 6 or 10 weeks. So I say, be prepared to just have no change for a little while until some restorative mechanism actually occurs. So we see some benefit around 6 to 10 weeks, and then kind of peaking at 3 to 6 months, and then kind of leveling off there. So at that point, at 6 months, we decide, was this a success, and should we offer another treatment at the time? And that's kind of what we use. Another question came in about nerve damage. What's the science on treating neuropathy? Larry, any comments on that?
Yeah, I think that's a really hot area, right? So I think this is something that is just coming to the forefront of the research community right now, particularly understanding the interactions of the cells that live in the disc with all of those nerve endings. So there are some really interesting gene therapy targeted approaches that are kind of trying to use cells in the disc to quiet that chronic pain from neuropathy. So I would say those are more like the 5 to 10 years away because they're just being investigated right now. It's an important question because while the degeneration of the disc is often coincident with pain, they're not exactly the same thing. And as Dr. Singh said before, what's causing that pain? Is it inflammation? Is it impingement? How long has it been going on? If it's recent, it's much more likely, therapies are much more likely to be successful targeting the structure. If it's been for a long time, then you're going to have to look at neurogenic pain and things that target nerves. So it's a little complicated. What's causing it and how long have you been having it are critical questions to ask in deciding what kind of therapy.
Absolutely. Someone asked a question about pain after compression fracture and the kyphoplasty surgery did not work. And this is a perfect example. What was the objective and the goal of the kyphoplasty? Probably to provide stability and prevent that bone from getting worse and compressing further, causing compression of the spinal canal, which it probably did what it was supposed to do. Yet, there are structures behind the spine, like the facet joints, like the muscles, like ligaments that probably are painful now. And yes, those could be targeted with a number of different interventions, whether it's a lidocaine or something called an ablation, and leading up to some of these regenerative treatments. But again, finding the pain generator and the diagnosis are unequivocally the most important thing before venturing in any of these treatments. Someone asked a question about NSAIDs, non-steroid anti-inflammatories, Motrin, Aleve, Advil, ibuprofen. Typically we stop these a little bit before the procedure and 2 weeks after for the reason I mentioned. Remember, this is a pro-inflammatory treatment, not an anti-inflammatory. So if you take some of these anti-inflammatories, theoretically, and some of the data has shown that you're going to halt some of those signaling mechanisms to bring cells to the site of injury. So we do tell patients to stop anti-inflammatories for a little while. Probability of infection. Anytime you put a needle in the body, there's a risk of infection, risk of bleeding. The disc, of all places, is a very avascular structure. There's not much blood flow, which increases the risk of infection even further. So we're very, very cautious and careful about putting anything into the disc. I try to rule out any other source of pain before venturing into the disc. That's kind of the last place I want to go. And when I go there, I want to make sure this is what's causing the pain, and I have a right tool or right treatment in my hand to optimize the pain relief. What else, Larry? Closing comments. We're kind of nearing the end of our spine time. Anything else for kind of the listeners and the viewers to take away from our webinar today?
Yeah, I just reemphasize, this is an exciting time. I think we're just at the kind of tip of the iceberg in a good way. I think we'll see these kinds of therapies start to come online in the next 5 to 10 years, and really good, solid therapies that have gone through the FDA process. I can only re-emphasize what Dr. Singh said before: buyer beware. Odds are that if where you first heard about this is on a billboard in the Jersey Turnpike, I would be a little suspicious. If you saw something on clinicaltrials.gov and you heard on the news that it was approved, I would trust it a little more. So realize that because it's on the cutting edge, we still don't understand everything, and that lets some people who are dishonest actors take advantage of that. So really, buyer beware, do your homework, and trust the science.
Absolutely. Yeah, and someone asked a question about, they came and saw one of our specialists here at the center, and these treatments were not discussed. And that's intentional, because these are tools that we don't want every doctor just to use. We want those that are studying it, that are involved in the clinical trials, that are working with the basic science team to really figure out the best outcomes. But that's why we do this, to share this information with you. There are docs such as myself and Dr. Hartle and Dr. Bonasser here at the Spine Center offering these treatments for patients. And the best way to see if you're a good candidate is to call us. Call us, schedule a video visit, come see us at the center. We're happy to discuss options. Our objective at the end of the day is to optimize your function, minimize your pain, get you back to doing the things you like to do. So thank you all for joining us on our Spine Time webinar. The next one should be coming up in 2 weeks. The topic is to be determined, I believe, but we will be sure to send out a mailer to everyone. And thank you, Dr. Larry Bonasser, for spending time with us and sharing certainly very, very high quality expertise on the subject matter. We would not be as far along clinically as we are without obviously a lot of your scientific work. So thank you for that.
Thank you for the chance. It's great.
And to all the listeners and the viewers, thank you all for joining us on a Wednesday night. Remember, when it comes to your back, we've got your back here at the Spine Center. So everyone have a good night. Take care.
Take care, everybody.